Well, welcome to Brookings, Dr. Clancy, and thank you for joining us.
A pleasure. Thank you for having me.
I wanted to really just pose a couple of big, broad questions and let you react to where we are in the conversation and more generally, any thoughts you have on the state of veterans today in the United States and things you think we should know about. So I want to ask a big, broad question to start. But I wondered if, before that, you could tell us a little bit about the position you hold at the Department of Veterans Affairs and what it means to be Deputy Undersecretary for Discovery, Education, and Affiliate Networks, if I got that right.
You have it exactly right, and if you actually paid attention, it spells Dean. So I tell a lot of people I am the Dean for Veterans Affairs. I almost have the Secretary trained to say that. But the VA has some very, very important academic assets, which means that we're constantly focused on some of the problems that this survey and other sources are surfacing and trying to figure out how do we do it better. So today, and yesterday through Friday, we have researchers meeting over at the Washington Hilton from all across the country, and they are presenting their work on pain management, on improving mental health care, on a whole host of issues, and not just sort of the what to do, but how does it work in our system, because that's really the holy grail. How do you build a learning healthcare system in such a way that we figure out not just how to do a good study, that's great, but what's the best part is to actually figure out how do we work with our partners in operations to make sure that it not only gets implemented in practice, but wherever a veteran shows up seeking assistance, even if that's on the other end of a telehealth connection, they're going to be getting the best care possible. So we have research. Most of our facilities, we think all but one, have some effort going in teaching the future health professionals in this country. Now, the partnership with the nation's medical schools goes back to just about the end of World War II. So General Omar Bradley, and we will celebrate the 75th anniversary next year. We're really looking forward to that. But to put it in bolder terms, we support 1/3 of U.S. medical residents every year, and about 70% of practicing U.S. docs have had some training in a VA. So we have a big impact on future health professionals, and it's not just docs, it's nurses, it's pharmacists, it's physical therapists, fill in the blank, and we're probably training those folks, which is wonderful. And the third piece is healthcare innovations. So we've taken a page from the Wounded Warrior Playbook and partnering with a lot of entities, which is another big theme of Secretary Wilkie's, is partnerships. Trying to figure out how do we do it better. So just to give you an example, we recently had a hackathon with MIT's Hacking Medicine program, and it was over at Samsung's building down by Eastern Market. So, you know, all these eager beavers, I thought they were staying overnight. Now, I have to say I was a little disappointed. They have to leave at 11 and, you know, go someplace to sleep and then return. But nonetheless, they were all busy trying to solve problems. While I was there, I met someone who had won a prize before, like in the past year or two, and he's come up with, he's got a company and a way for a veteran with diabetes to step on a particular pad, and the temperature difference where a foot ulcer might be forming can actually alert that veteran's providers that they need to take action to prevent, hopefully, the occurrence of foot ulcers, and really importantly, to prevent amputations and so forth. So that's the kind of work we do, and it's very, very important, but we're not stopping now.
Fantastic. I wondered if you had any other thoughts, reactions to what's been said today, most recently by Dr. Lawrence, but more generally, I guess the way to frame the question would be, how would you take stock of where we are today in the United States in handling the challenges facing the veterans population? Where have you seen progress? Where are you most concerned about unmet need?
Sure. So where I've seen progress a lot is in access. Some of my colleagues and I published a paper right at the beginning of 2019 looking at wait times in our facilities compared with private sector wait times in about 15 major metropolitan areas. Now, it turns out, notwithstanding our places where we had big backups in wait times like Phoenix, because our facilities had not caught up to where veterans were moving and so forth. And we had a little tiny bit of telehealth going on, but now we have a whole lot more. In the private sector, at a very high level, we were about the same. Since then, we have improved a lot. And for the most part, the private sector has not been moving as rapidly. So I think access is better. And more to the point, we've put a big premium on same-day access today if you have an urgent primary care or mental health problem. Now, that may or may not involve your getting in the car and coming over to the facility, right? Sometimes an urgent problem is, you were supposed to fill my meds and I didn't get them. Can you check that it should come by today, or if not, how do I get an emergency supply, and so forth, or I need a form approved or something along those lines. But the point is, that's probably 22% of all of our appointments, so I think access is better. There's a growing number of studies that show that the quality of care we provide is equivalent to or better than the private sector. So when the Rand Corporation or a researcher from Dartmouth does this, I put some faith in that, right? We can do these studies, but it certainly feels like it has more validity if an external group produces those results. And I think those are probably the biggest areas. Can we get you timely access to safe, high-quality care? Do we have problems? Yes, we do. Do we have problems that are not seen in the private sector? To the very best of my knowledge, based on my prior life before I came to VA, no. What we have is far more transparency. That's completely fair for a publicly financed system. But, and this is not to scare everyone, but just to say that, what happens in our academic partners, medical centers and so forth, or any private sector facility does not get that same level of scrutiny. For the most part, it's actually been a good thing for us. So I think those are where the big improvements have been. The one other advantage, and this ties back to Dr. Lawrence directly, for those of you who care about healthcare, I mean in a policy sense, one topic that people talk about a lot are social determinants of health. All things being equal, if you have lower levels of education, lower income, housing problems, and so forth, your health is going to be worse. And guess what? Even if you run right into Dr. Oz or, the best doctor anywhere, that's still going to be a tougher set of challenges, whether that's paying for prescriptions or the best kind of, meter to test your blood sugar or whatever it is. It's harder if you've got those problems. And for those problems, we can provide a lot of support for veterans through the GI Bill, through employment assistance and a whole host of services. So we see the Benefits Administration as pretty vital partners. Unmet need, I would say we have a mental health crisis and a suicide crisis in the country. Thankfully, it's gotten far more attention among veterans than the rest of the population, but I think the rest of the healthcare system is slowly coming to grips with this. You hear about this in the clinical community because there's reports about burnout, right? People feel like this is not giving me a great deal of meaning. And it used to, but it is not anymore. That's one manifestation. At a time when we have insurance parity, there is still a huge, huge stigma with mental health care. So we have an executive order now where we're focusing on suicide prevention, not just for the veterans we see. We do that, of course, but for the veterans everywhere. And frankly, we're going to need help of Wounded Warrior Project and many, many other groups to try to figure that out.
On that point, the Wounded Warrior Project, of course, focuses primarily, or I think exclusively, on the post-9/11 generation, and that's pushing 4 million individuals, I believe. But I think there are more than 20 million veterans in the United States still alive.
Yes.
Are there certain problems that you see more often with the Wounded Warrior Project population, so to speak, with the post-9/11 generation? Or, for example, is the risk of acute mental health distress and suicide, is that evident across all veterans' demographics?
Well, we know that among veterans, the largest number of suicides is in the 55 to 74-year-old age group. The highest risk, though, is 18 to 34, and I would guess that's mostly going to be the veterans for whom Wounded Warrior advocates for specifically. We are now at a time of getting where we have an all-volunteer Army. One of the issues that we struggle with in healthcare, and every healthcare organization struggles with this, is let's be honest, 18 to 34 or younger than me, are far more tech savvy. And frankly, they don't get this, come to the waiting room and hang out with your buddies and we'll get to you. And, you'll be very pleased when we do get to you, but, we don't have that much respect for your time. They're much, much more hip to virtual modalities. And, one of the people who works for me, who is a constant source of insight and intel, more or less tells me with the demands on his time, he's raising a son by himself. Occasionally he's got another job on top of his day job. And he'd like an app for when he's going to the DCVA to tell him how the appointments are running. Well, you know what? I'd like that too. So far, my provider doesn't seem all that inclined towards getting it. But, when you can sign up for doctors online with ZocDoc, you can do this now with VA as well. Why shouldn't we have that kind of capability? And frankly, I think younger veterans put a much higher premium on convenience. I get that. There's only 24 hours in a day, and if you've got a lot of demands on your time, that's just how it's going to work. Thank you.
One last thing for me, and then we'll go to the audience for the remaining 10 or 15 minutes. And again, thank you so much for being here. This question's a little different. It's not so much a policy question, but I'm picking up on the mental health issue. And I wonder if there's a message you would want to give to anybody who might be listening and experiencing mental health distress, who's a veteran or even not a veteran for that matter. Is there a message about what's the first step? What do you do when you're in that moment? If we have this national crisis, but we do have capacity to help, what do people who are experiencing the worst of their lows or their anxieties, what do they need to hear from a healthcare provider?
Well, first of all, if you're in crisis, I would want everyone to know about our crisis line, which is 800-273-8255. You might want to put it in your phones right now so you'll always know it. So it's 800-273-8255. I think, and you don't actually have to be standing on the ledge, metaphorically. If you feel like you're in crisis, it is a great place to call. And I've been extremely impressed for veterans enrolled in our system, as well as others, how quickly we can reach veterans literally almost anywhere. Several years ago when I was acting undersecretary for a year, I actually started getting emails from veterans that said something like, I don't know this person, but I saw him on my Facebook. Can you help? And the answer, the vast majority of the time, was yes, we can help. We can figure out where this person is, and because we are a very large integrated system, and that's a great capability. I think if there's one advice I would have for everyone sitting here and everyone is don't be afraid to ask people about it. Again, that's the one manifestation of stigma we all deal with. It feels like a little too sensitive to ask someone, gosh, you're seeming kind of down to me, like how down are you and can I help and so forth. Sometimes that feels too private to people, but people get that message non-verbally, right? And so they don't bring it up with colleagues and so forth. And it is never, never really the better idea not to talk about it. So if you are worried about someone, tell them. Even if this is the furthest, actual suicide is the furthest thing from their minds, no one is going to mind that you say, I care about you and I'm concerned. If the unthinkable happens, not talking about it is horrendous. I've had it in my immediate family, and frankly, what I felt insulted about were people who didn't want to say anything. I know they thought they were being very polite and concerned about me, and therefore the politer thing to do was not to talk about it. What do you think I was thinking about 24/7? The recent death. And so those are what I would want, and that we want to help. And if you have ideas or gaps, please let me know. Carolyn.clancy@va.gov. One of the issues that I'm working on in particular is how can we help people in the workforce actually deal with their own mental health resiliency, dealing with emotional stress and so forth. And a growing number of employers are starting to get into this, which I think is phenomenal. But in particular, for those who deal with the public, which may include veterans, right? How do they recognize signs that someone is, in a bad place? Now, sometimes Dr. Lawrence's people, right, are hearing from veterans who say things like, I am so frustrated with your system, I could kill myself. Now, often that is a figure of speech, and sometimes it's not at all. And trying to figure out how they can do that, how they can recognize that and express concern and assure someone that there's help available. And again, any veteran with an acute mental health problem, regardless of whether they're enrolled in our system, as long as they have not been dishonorably discharged, can come in and we'll see them right away.
Thank you very much. Let's go to your questions for the remaining 10 minutes or so. And again, please wait for a microphone and identify yourself if you could. Got a gentleman over here, please.
Hi there, Dr. Clancy. I'm Rajiv Ramchand from the Bob Woodruff Foundation. One of the results from the Wounded Warrior Project survey that I'm struggling with is this 70% of respondents report exposure to toxic substances or hazardous chemicals of the post 9/11 era. I'm curious, is the VA, I know that they have a registry, has the VA made headway on what what diseases and illnesses those exposures might contribute towards or increased risk for? Do we know that? And then this finding that 9% have sought care, I don't know whether that's a good or bad number. Should veterans who feel that they've been exposed to toxic chemicals seek care, and what should they be asking their provider about? I don't want to put you on the spot. I don't know the answer to that. But
No, I'm really, really glad you brought this up. Yes, we do have a registry specifically focused on those individuals who have had some exposure to burn pits, and we're learning a lot about it. So you've got two things going on. One is a sizable number of people who've had this exposure, some of whom are experiencing some difficult lung problems, right? Now, we still have a lot to learn with how much of that is primary from the burn pits, how much of it is exacerbating some underlying problems that at best were minor to trivial before they entered service and so forth. And we won't stop till we get some of these answers, and we have some really, really terrific people working on it, both within VA but also outside as well. At the same time, right, that's true. What else is true is that many veterans, particularly in the 9/11 era, and it's funny because it's a reflection of medical success in the battlefield, right? The mortality rate has been dramatically lower than in any prior wars or conflicts. That's the good news. The slightly less good news is that people come home with more, the medical term is comorbidities, right? That could be the form of serious bodily injuries, and it could be so-called invisible wounds. And this leads many people to wonder, is all of this stuff related to toxic exposures? We don't know all the answers, but we won't rest until we do. We're working with the National Academy of Sciences and doing a lot of research internally. In fact, our executive in charge just asked for a full briefing on this, and I was exhausted just looking at all the information we have. And so it is a very, very big focus for us.
Thank you. Gentleman here in the 10th row or so.
Good afternoon, Dr. Clancy. Greg Nemhard with the American Legion. You touched on some really good points about what the VA is doing and I guess the advancements in scheduling and access and everything compared to the private sector. We, and I use the term we because we veterans are really good at spreading bad news about the VA. We have often succeeded in doing that very well. I have a lot of veterans that come up to me and say, I don't go to the VA because of this, this, and this. And a lot of times it's because of something they heard from somebody else, not even their own experience. Programs like what we're doing here, Dr. Lawrence's updates, these are really good things about getting the good word out there. Have you been able to measure just how well these are doing, how much we're getting the word out about the VA through programs like what we're doing here?
I'm going to say this as diplomatically as possible. I can't say that that kind of communication is one of our strongest assets. Coming from VA. So to the extent that your organizations can help us, that's greatly appreciated. But you know what? You learn a lot when people complain. And we're so acutely sensitive to that in all of our facilities now, we do something called V for veteran signals, right? Where we're getting a lot of real-time feedback. Now, some of this is about predictable things. I had to wait for 15 minutes, or that clerk wasn't as nice as he or she could have been, and so forth. But that feedback gets to the right place, and we deal with it. And sometimes it's surprising. You know, in one network, they got a lot of complaints about pharmacy, and we're sort of surprised and almost a little hurt because they thought that was an area we did very well. And come to find out, there were some serious glitches, and they fixed them, and that. But you know, that kind of real-time feedback and reporting is only as good as the service recovery that goes with it. So really, we have put a very strong focus on that. So when people complain to you, I would tell them to let us know, so that, and we're happy to deal with it.
Anyone else? Time for one or two more, if anybody would like. Ma'am, right here. We'll make this the last question.
Kate Watson, Your Next Stage. We focus on women vets. My question is, and maybe there's an answer out here and I haven't read it yet. Are you finding, what are the difference in clinical outcomes from those things that are social media driven, for example, telehealth versus high touch? Is that something that you're looking at? Is there some data out there that I could get a hold of?
You know, that is such a fantastic question. I can't say that we're actively looking at it now, but we need to. There's no question about it. Of course, we're excited that we had 2 million encounters last year with veterans via telehealth. And in fact, I love this. Last week in Eureka, Montana, you know, at the local VFW hall, they now have this special booth. It looks a little like the Mamavas at the airport, if you've seen those. I don't think that was intentional, but the point is that it's private, where veterans can go there for a telehealth encounter. And, you know, so in areas without broadband access, widely available and so forth, you know, this is something of a godsend. But we still have a lot to learn about when it is far, far better to be in person and when telehealth is just as good. We have a lot of evidence about mental health. You know, so someone from the University of Washington not long ago and worked with us a lot to make sure that we had mental health providers in all of our primary care teams across the system. He told me that one of the residents he thought was one of the best he ever trained was now serving veterans in Amarillo, Texas, but he was not giving up his views of Puget Sound, where he lives. And increasingly, we're going to hear that, but thankfully, there's been well over a decade of very strong evidence that that works well. For other kinds of issues, I think we're still learning. At the same time, we're partnering with an organization, for example, that uses a doctor and coach duo, and it's almost all virtual, to help veterans with diabetes. And they're seeing some pretty dramatic results and improvements, which is not a problem healthcare has excelled at, right? Because it's not easy. Hey, nothing to it. Just to forget everything you really want to eat and exercise like crazy. Anything else? I mean, right. But, you know, with that kind of coaching and motivational approach, that seems to be working. So I think that we have more to learn about the relative strengths and limitations of both.
Well, let me thank everyone for coming today and thank Joe and Melanie and Jen and Dr. Clancy and everyone else, Dr. Lawrence, and all the veterans in our communities who have done so much for the country and all their families and friends who do so much for them and for all of us. So best wishes, go Nats, and have a great
Yes.
happy Halloween.
And thank you all.
Thanks for watching. Be sure to like and subscribe for more videos from Brookings.